Hello, everyone, and welcome back to the Outcomes Rocket. I'm thrilled to be doing this ASC Insights podcast series in partnership with Medtronic. And we're diving deep into the ASC space because this is where healthcare innovation meets operational efficiency. And if you're looking to transform your healthcare organization, and if you're a leader with your mind on this space, this is the place to do it. Today, I'm speaking with Dr. Adam Thaler. He is the medical director from Summit Health, and we're excited to hear more about his expertise, his point of view on the ASC landscape. And I know he'll also be telling us about his experience implementing technology like McGrath MAC, which is a video laryngoscope solution for those who may not be familiar. So, Dr. Thaler, I just want to say thank you for making the time to be with us today.
No, it's my pleasure. Thanks for having me.
Of course. Well, look, let's kick things off. To start us off, can you share a little bit about your ASC, who you serve, and the kinds of procedures you focus on, and how you see your center contributing to that broader shift toward outpatient care?
Yeah, of course. So our center focuses solely on urology, which is a subspecialty of surgery. So we do types of procedures from kidney stones to vasectomies, prostate biopsies, to bladder tumors, and even some prostate tumors, even some bigger cases as well. So anything that could be an outpatient stay, we review these patients as long as they have appropriate criteria to be done at a surgery center. I review every single one myself as the medical director. I bring patients in that might have a high BMI or any certain conditions that I'm concerned about to make sure that they're a good fit for our center. We get the appropriate labs, consults, and anything that we might need beforehand. And it's been a great experience. I started this center 3 years ago with a urologist friend who brought me in from my first job out of residency. And he asked me if I was interested in this opportunity. It sounded exciting and great and interesting, and hit the ground running. And it's been amazing ever since. Patients love the experience. As you said, surgery centers, anything outside of the hospital has been growing exponentially. I think there's some data to show that more than 50% of all procedures now are done outside of hospitals at office setting or surgery centers. And it's going to increase probably to 65% in the next 5 to 10 years. So it's a space we definitely need to discuss and figure out what the best way to go about different decisions in that setting.
Yeah, no, I appreciate that, Dr. Thaler. And you're an anesthesiologist by training, right?
Correct. Yeah, I trained at University of Pennsylvania. And from there, I went to Virtua Memorial Hospital, which is in Mount Holly, New Jersey. I was there I ran the operating room there and was there for 5 years, and then spent 4 years at Thomas Jefferson University in Center City. And from there, I then took this role. And during that time, I've always been interested in the airway. So that's one really exciting thing that from very early on, when I was a resident, and we would have these intubations, which was the number one thing I was most nervous about from med school going into residency. There'd be like certain attendings that said, that I could intubate a rock. He's the best. Now, all of a sudden, 10, 15 years later, intubating isn't no longer a skill that someone's like, oh, well, that guy's really good at it, because of the innovations in video laryngoscopy, which we can discuss. So it's been a fun road, and I've done a lot of research on my own with it to look at cost and other factors to see like what's the best fit for me, myself, and for other individuals, and for training, and for surgery centers.
That's awesome, Dr. Thaler, and really appreciate the context of your background. And so as we look at ASC operations, that day-to-day, you mentioned Airway, and I'd love to take that context and sort of expand on some recurring challenges around patient safety, clinical workflow that leaders like yourself need to solve for. Speak to us with that lens around airway management.
Of course. So airway is ABC, right? Airway, breathing, circulation. That's like the first thing you think about with anesthesia. Airway being the most important. Like when any anesthesiologist looks at somebody, it's just by habit, whether you're at the store or on a plane, you look at somebody's airway and their chin and their neck and their mouth, and to think, oh, is this person going to be challenging for me? And I'll tell you, going from an academic setting to a private practice was even more vital with looking at Airway, because at an academic center, you have not just all the tools, which hopefully you have at a surgery center, but you have all the resources. You have CRNAs, residents, other attendings. You have a whole assortment of colleagues. If anything goes wrong, you just touch a button and everyone comes running. And so you have ENT, you have trauma. They can just make a little incision right here, which is not ideal. It's not what you want, but that alone can save a life. Now I'm at a surgery center. I'm on an island. You're by yourself. Occasionally there might be another anesthesiologist in a different room or CRNAs, but I have to look at it as I'm the last line of defense. So I have to plan for A, B, C, and D. So what happens if I can't intubate? What happens if I can't ventilate? And so you have to think, okay, if I can try this option and then that option and go down your toolbox, because that's it. Like if I'm not able to be successful, then unfortunately the patient's not going to do well.
And that's a great point. In the context of the ASC, while it's convenient, you don't have the expanded team to support you. You really have to be able to solve for that. And so therein by yourself and with the tech that you have. So as new tools and technologies become available nowadays, how do you approach evaluating what's right for your ASC? And meaning like what criteria or decision-making framework do you use to separate the nice to haves from the must haves?
Yeah, no, that's a great question. So when I came to the center, it was a requirement, not an ask or a want. It was a need that I would have a video laryngoscopy. And the one that I preferred was the McGrath MAC, not just from experience, from portability, from ease of use, and so forth. The McGrath, and I have a funny story because I remember when I was at Virtua, my first job out of residency, I never heard of a McGrath. We occasionally would have a glide scope when I was at training, and it would only be for those crazy airways that you can't get with the direct laryngoscopy. And it would be down the hallway. Someone would have to like ship it over. It was like asking for like the most insane thing. And then I get to my first private practice job at Virtua, and they had this one McGrath MAC that was locked up in a Pyxis, which is where you get medications like narcotics with the fingerprint. It was a whole to do.
So they had it in a Pyxis? They had it in the Pyxis?
Locked up. Like what? And I'm like, what is this thing? I noticed the first few years of being at Virtua, I knew that we had one. I didn't know what it looked like. I was like, what is this thing? It's secretive, it's hidden. And then I had a difficult airway on a floor in ICU. And, I wasn't the first person there. I was the second. They had a difficult time with it. And I'm like, we need a glide scope, because I knew we had a glide scope downstairs. So I run downstairs, because I'm like young new attending at this place. I grab the glide scope, I run up the stairs. I'm like holding it like this, and I bring it. And fortunately, it was in time where, I was able to use it and be successful with the intubation. And then I asked my colleague, my older attending, and I go, we need a better option. And then they're like, oh, we have that McGrath. And I'm like, we do. Why don't we use it? And I started always carrying the McGrath MAC whenever I was on call, because I'd be by myself. Like we discussed, the surgery center, I was on call, and I would have this for airways. And I never had that fear. I never had that stress anymore, because I knew that I could use this right away. So now fast forward to today, I made sure that we would have a McGrath MAC in every OR. So we have 3 operating rooms, all have McGrath MACs. I use them for every intubation. We don't even attempt a DL. We have the DL in there because they bought them before we even started, before I came into the center, when they were just getting us ready, and they're like the disposable ones. And then I even said, I was like, the disposable ones cost a lot more than the McGrath MAC. And they're like, oh, they do? Like, yeah. And not only that, but we all know the studies, and I can cite them later if you want, of the difficult intubations that are unknown that you have a DL for, and then all of a sudden the airway could be complicated, and now it's going to be challenging for a VL. You have the first pass intubation that Emma trial shows. So your first try is going to be a lot less likely to be successful, even with an advanced partitioner, than with a VL. So I wanted to make sure I'm by myself, I'm on this island. I want to make sure that I have the best chance for success. This is going to be the best for my patients. It's going to keep them safest, and it's going to limit complications. So for every intubation, we use a MAC, a McGrath MAC.
Well, that's really great. And so you took a look at all the options out there. You went with McGrath MAC as your choice to help with some of these airway challenges. It's small, it's convenient, it sounds like. So once you decided to move forward with the McGrath MAC, and thinking about this with McGrath in mind, but also as surgical center leaders listen, how does a successful implementation look like? And how do you measure whether it's truly delivering value for patients, staff, the business? Like, talk to us about that with your evaluation of McGrath.
Yeah, good question. So first I did a study comparing the McGrath MAC to the glide scope, and I was looking at just apples to apples, like two of the most common used VLs on the market, not even considering like the portability, the ease of use and so forth, just which is, more cost savings. And it was a 55% cost savings with the McGrath MAC over the glide scope when I did this study, which we can look at, and I can show in citations. And then I did a study looking at VL, looking at McGrath versus DL. And it was looking at just direct cost savings. It wasn't, the DL is only a few dollars less when compared to the McGrath. But then if you look at the indirect cost savings, it's insane, because I'll tell you, I was involved in one horrible complication at this institution, or I witnessed a difficult intubation with a DL from a med student and then from a resident, and ended up being into a surgical airway. Patient survived, but it was an ICU stay. It was, echoes. It was a lot of like stuff, and it was $200,000+ later. This could have been avoided with a VL as the first attempt, because after DL, then the airway got edematous and more challenging, and then there was severe bronchospasm. This was a horrible situation that I was aware of, maybe like beginning that I heard about. And this could have been avoided, and that cost savings alone shows you how much this could have been a difference in that. And so now fast forward to the surgical center environment. You have cost when you have sterilization, right? So then you have to like implement that with the DLs if you did do DLs at a site. And now you've got VLs, which are very cost effective, which I'm showing you now, are less actually than the DL that are disposable. But the indirect cost savings and the patient satisfaction is number one for me. Having patients do well is number one. One thing that I had an older colleague and I had asked, I was like, how do you decide if you want to do a DL or a VL? And they're like, oh, we need to keep the DLs for the training purposes of upcoming students and residents. And I go, okay, well, what's the concern? Like, what's your worry? Oh, that wherever they go from here won't have a VL. I'm like, but every place can have a VL now. Like it's commonplace. It's economical. It makes sense. And they're like, well, what happens if the battery goes down? I'm like, well, what happens if the DL light source goes down? You have a second one, right? They're like, yeah. I'm like, couldn't you have a second McGrath and also some batteries? Oh, that's true. But they need to learn the anatomy. They need to learn. I'm like, well, wouldn't their anatomy, you learn more by having an attending watch with a video camera of what they're seeing with the arytenoids and the vocal cords and everything that in epiglottis, everything they're seeing. And it was really funny to go back and forth with an older attending, talk about, and that's one thing that I was kind of like going back and forth and rebutting and play devil's advocate. But the other thing is, whenever you have a VIP, right? Let's say they're a famous person that came to our institution, or maybe someone's friend or whatnot. I would notice
son or daughter or something like that.
I would notice they would use the VL, and I go, why? They're like, oh, well, the odds are a little bit better of success. I'm like, okay, so you're worried about what? Damaging their tooth or their lip, or you don't want to give them a sore throat, or just the sympathetic stimulation that comes with the DL. They're like, yeah. I'm like, so if you're going to do that for somebody that's a VIP, why wouldn't you not treat everyone that way? Like, that's how I would want to be treated. And they couldn't come back from that point. And so like, that's how I look at it. I want to treat all my patients the way that I want to be treated, the way that a VIP is treated. I give all my patients the same care as if they were, a family member. So when I look at as a leader in a surgery center, how I picked the McGrath MAC was I wanted something that was economical, safe, and the best in his class. And I think that that is what the best in his class today.
Man, that's so cool, Dr. Thaler. And I love the example that you use with those VIPs. Everybody could be, and the tech is there, the price point is there. I think it makes so much sense. Look, one of the big things that we want to do with this series, other than offer practical experience and tips, just as you have been with this Airway example, is really helping people look ahead. What lessons or advice would you give to other ASC leaders that are in your seat, exploring innovative ideas to help in this fast-growing landscape of ambulatory surgery centers?
I think it's important to be open to change, though. Be open to something new on the market, right? You have to do your own research. You have to do your own homework, because the difference between me now, I've been here 3 years, versus me, before, is you're hearing your colleagues, you're hearing young residents that are in fellows and that are asking you these questions and, seeing this technology and making you think. Now, all of a sudden, no one's really asking me those questions. So I have to do my own homework. I have to maintain my continuing medical education, of course, but I have to do more than that. I went to the ASA last year. I looked at all the new and hottest equipment. I talked to my colleagues at not just other surgery centers, but at the big hospitals, and say, like, what are you doing? What are you using? What are you doing for this? Because things keep changing. Things are constantly evolving, right? And so, especially in the AI world too, like, there's a lot of things that are coming up too that are very interesting in our space. So I think the key I would recommend anybody is just staying present.
That's great, Dr. Thaler. Really appreciate that closing advice. And as it relates to the McGrath MAC, like, connecting it to the bigger picture, it helps with the airways, but how does it help operationally? And what tips would you give folks in your seat to help them with their ASC operations?
So it does help with how long it takes to intubate a patient as well. So comparing that McGrath for me to the DL, I'm going to be a lot more successful with my first attempt with the McGrath. The DL, if I'm unsuccessful, now all of a sudden I have to start bagging, mass ventilating the patient again. I have to give more propofol, I have to deepen them to avoid bronchospasm. So that's one, just comparing DL to VL. And then looking at that cost, like we mentioned before, it's more economical. For a disposable blade versus the McGrath, it's way more economical to use that McGrath. And then also the time savings. I think it's hard to measure this because there's a lot of factors. Like you can look at med students from residents and versus like a young attending we're attending, but it's definitely a little bit faster when you have that muscle relaxer on board, and then you take a look. You've got less heart rate and blood pressure increases because of the force isn't as significant. You see that beautiful vocal cord opening, and then you can pass it, and it's so smooth. You're avoiding giving certain medications because you're avoiding that stimulation as well. So patients seem to be doing better. The surgeon can start sooner, even though you're still relying on the end-tidal CO2, the bilateral breath sounds, the fogginess in the tube, you're still seeing those signs to make sure you're in the right place, end-tidal CO2 obviously. But you watched it go in. So you can start, especially in the surgery center setting, you can say, yeah, you can put the legs up. Hey, you can start doing your thing. Like, I'm good. So a little bit more timely, just more comfortable, like knowing that the airway is secured in a good fashion.
That's great, Dr. Thaler. Well, look, I certainly appreciate you sharing these insights with us on this series. One of the best ways for people to learn is to listen to these podcasts, but the way that you really make it happen is you connect. So if people wanted to ask you questions or get in touch with you, what's the best way that they could learn more about you, your research, and the work that you're up to in this space?
Yeah, there's a blog that I did with Medtronic last year, and I went over a couple of different really important studies, some that I did and some that others did, that we could attach here. I can put my email for someone to reach me, because listen, I want to help as many people as I can. I used to, when I was at the teaching hospital, I was able to help the residents and med students and interns. And I was guiding so many different people into anesthesia just because they loved the way my passion for it and how I talked about it and the importance of it. Now I don't have that same pedestal. as I'm no longer going through the professorship track, but I can go to the ASA and speak, which I did last year, and I'm hopeful to keep doing. I can do podcasts. I can just give my story to as many people as I can to show how important certain devices might be, but also anesthesia is. I mean, I'll tell you what was really cool is I had I tore my meniscus and I had surgery 10 days ago, and I didn't know who my anesthesiologist was going to be. Obviously, I picked my surgeon, and the anesthesiologist walks in and he goes, "Thaler, how are you?" He's like, I was like, what do you want for your anesthesia? Because it turned out to be somebody that I trained at Jefferson.
Oh, no
I was
kidding.
Like,
Wow,
you're the best. I'm so excited when I saw your name pop up. He's like, and then he's like, "What can I give you? What do you want?" And I'm like, Barnaby, I was like, you know what to give me. Like, I'm not going to like pick, treat me the same way you treated the other patient in the next room over. It's fun. It's like, it's a great niche, and it's important because we are pioneers in surgery. So, we're behind the drape, don't always get that credit, but we don't need the credit. We just want to make sure that patients doing a great job. Like, they're so scared about being they're scared about of waking up and what's going to happen. And, we can do a really good job keeping them calm and safe, preoperatively, but intraoperatively with what we have in our tools.
That's brilliant. Thank you, Dr. Thaler. There you have it, ladies and gentlemen. Thanks for tuning in to an outstanding podcast today with Dr. Adam Thaler. He's the medical director at Summit Health. We're super excited that he was able to join us. Check out the show notes for all the summary of what we've talked about, the blog that Dr. Thaler mentioned, ways to get in touch with him, and at the end of the day, ways that you too could be successful in the ASC space. Dr. Thaler, thanks for joining us.
My pleasure. Thank you again.